We're going to talk a little bit about the small molecule inhibitors in a second, but just stepping back again to the chemoimmunotherapy regimens, I wonder if Susan can comment on, since we're here at ASH 2015, if there are any particularly interesting, exciting chemoimmunotherapy combinations with the small molecule inhibitors that you're looking at the abstracts and excited about?
Well, I mean, I think there are many. There's a whole bunch of them, and I think the key question that always comes up when we look at that data, and most of it's in relapse, to be fair, is we get such good results with the small molecules, how much is the chemo adding? And when generally the question is being asked in reverse. If you add, let's say, ibrutinib or idelalisib, because we heard about the ibrutinib BR data at ASCO, and we're hearing about the idelalisib BR data here at ASH, and the point that always comes up is, well, do you actually get more bang for your buck than if you had just gone to the single agent? I think probably you can't completely answer that question when we look at these analyses, because the follow-ups are very limited. And it's certainly possible that by starting with chemo, you may get long, we know CRs increase over time with the small molecules. You may get to higher CRs or more MRD negativity. But when you just look with very short follow-up, in particular at the overall response rates, that question is coming up. So it might be that in the frontline setting, and again, most of these trials have not been done in the frontline setting where you get so much more benefit from chemo than you ever get when you give it to a relapse patient, that there, it really may be different. Of course, then what confounds how you're going to use that is this whole discussion that we were talking about earlier about, do we just want to get away from chemo and not even use it in the first place? So I think what we do know is you can give the small molecule inhibitors with chemotherapy. The real question is, where is that going to go? What's going to be the role for that? And I'm not very clear on that.
I agree. I mean, I think there's a lot of interesting data and a lot of interesting trials that are ongoing now with these combinations, and the endpoint is really the issue here. I'd like to move on now to an FDA decision is expected this month for a new rapid infusion formulation of bendamustine. A phase 1 trial that included 81 patients showed that a 50 ml admixture of rapid infusion bendamustine could be delivered over 10 minutes, and it was bioequivalent to Treanda given in a 500 milliliter admixture, which required 60 minutes to infuse. I wonder if Tom, you could comment on what you think the clinical or the community relevance of this is.
Well, I think you have to certainly respect the patient. We call them patient because they keep waiting for us in our treatment, and they have lives too, and so anything that can shorten the time in the infusion chair can potentially help the patient. And I must say that bendamustine is very commonly used here in the United States in combination with either rituximab or more increasingly obinutuzumab. I think that the use of the chemoimmunotherapy regimens with bendamustine could be improved by having a shorter infusion time. That seems obvious. And I must say, there's a lot of controversy about the benefit of BR versus FCR. I was convinced that FCR was a more effective regimen, and I think the jury's still out. The German CLL study group that did the comparison, it confuses me because in the patients that received BR, they were significantly older, and they also had a significantly high proportion of patients with unmutated antibody genes for their CLL cells. And we know that if you treated those two patient populations with the same regimen, you would have a more adverse outcome in the group that received BR. And the outcome was very difficult.
Tom, they looked within the mutated and in the unmutated.
I think you have to stratify that. But if you do, it's very difficult to parse this out. I think it still needs to be determined whether this is necessary, particularly with the advent of some of the newer antibody regimens and the advent of follow-up therapy to give to patients if they should not have as successful remission as we would hope. But I think it's confused the matter for me at least.
Well, I think what you're alluding to is, do we have better antibodies, and will perhaps using a not so myelosuppressive chemo be more acceptable with a more effective antibody?
Correct.
So that question is open. I think, it's clear, as you said, in the United States, people don't like to give FCR and they like to give bendamustine.
And this may make it easier. So if it makes it easier for the patient, go for it.
And we all know time is money.
Right. I indeed agree. So we talked a little bit about CAT scans and how in community practice, patient management, they may not be as critical for clinical trial purposes. I think they are an important endpoint to objectively show responses. I wonder if, Dr. Ma, you could maybe comment on bone marrow aspirate and bone marrow biopsies and where those might be useful in our management and assessment of patients.
Mm-hmm. So in a clinical trial, I think bone marrow biopsy is very important because that really, if you're calling a patient complete response, you have to document that they have a complete response in the bone marrow. And the same thing for the MRD documentation. The MRD negativity in the bone marrow is the most reliable factor to predict the progression-free survival, and the MRD on the blood is much less reliable. But in clinical practice, I think a lot of physicians are not doing bone marrow biopsy. But I would say that in certain situations, especially if a patient pre-treatment has significant cytopenia, then at that point, bone marrow biopsy is very important because it does help you to differentiate what is the cause of the cytopenia. Is it actually due to CLL infiltration causing bone marrow failure due to underproduction, or is it due to some autoimmune phenomena? Because autoimmune cytopenia is not uncommon among CLL patients. So some patient who has thrombocytopenia, for example, if they have adequate amount of megakaryocytes and limited amount of CLL, then likely that's due to autoimmune mechanism rather than the bone marrow failure. So in that case, you can simply treat the autoimmune disease rather than treating the CLL. So I think pre-treatment bone marrow biopsy is really essential for patients with cytopenia.